Okay, thank you very much, Mr. Deneen. All right, we're going to move right along to, time is, have to make sure we're on time here. We are. Mr. Tom Motes, are you present, sir?
As Mr. Chair, as Tom comes forward,
I was going to read the title. So go ahead. Okay, this is item number 5, the health plan review. This is a mini budget workshop. There is no votes on this particular item. We will be asking questions and discussing. Mr. Deneen, you have the floor, sir.
Mr. Chair, I know that the council, we've spent time with individuals. I know that,
Can we please have some peace and quiet here? Thank you. We are still working.
I know
Thank
that
you.
the council, this is a very, healthcare is, in some ways, we've got to tackle for the future. It's about a 2-year period and where we have to go through and decide what we're going to do for the future of healthcare. It is probably one of the biggest things that this council will take on. It is an absolute key element of the benefit that people get for working here, and one of the reasons they do work here is, aside from wages, people have to have benefits to survive in the healthcare benefits. The process will take us some time because it's very complicated. And while I know that each of you has spent time looking at this material and we have gone through this, I'm going to ask Tom to walk you through this together with Mr. Robinson, our consultant. I think it is absolutely crucial, and I don't think I can repeat this too many times, for us to go through the details of what we're facing on healthcare. And I encourage everyone, especially our employees, to tune into this, to understand how big an issue this is, and for the public to understand. I mean, it's one of the key elements when you hire people, and it's also, as we all know, one of the areas that has grown the most in cost, because quite frankly, the services are more expensive, people utilize them more, and one of the downsides to the downturn we had, when you reduce the workforce, and we're down over 600 people across the board, and we have not been hiring people. What that means is you're effectively have an older workforce. And I know this is going to come as a shock, but the older that people get, the more health care they use. Wherein, for example, one of our issues is that under the state law, we have to offer our plan to our retirees until they reach Medicare. Believe it or not, that group costs the most for the services between what we pay, or what they pay, and what we have to subsidize. It has everything to do with age. And so we have to deal with these issues. Tom will walk you through this, like I said, with Mr. Robinson. This is the start of this discussion, and I'd like not only to have the discussion here, but I'd like for everyone that's tuning in to start to get prepared about the level of detail we're going to have to get into. This is a very complicated subject and very important. Tom?
Thank you. Good morning. My name is Tom Motes. I'm the Human Resources Director. As Mr. Deneen said, this is a very important subject. I have with me today Mr. John Robinson. He's a consultant we've hired to help us on this item. He's with Robinson Bush, and he'll be going through the presentation this morning. So at this point, I'll turn it over to Mr. Robinson.
Thank you. My name is John Robinson, and I'm the president and CEO of Robinson Bush. We are an independent benefits consulting firm in Orlando, Florida, and as such, we are not in the sale of insurance products for any of the clients that we represent. We represent a number of public sector clients, and large public sector clients, and have done so for many years. So we appreciate the opportunity to be of service to you and talk to you about your health plan and some of the upcoming events that we have as we go through this particular presentation. What we would like to do is provide you with a clear and concise review of your health plan and do so in an executive summary type of format so that we can give you a lay of the land as to what your plans look like and talk a little bit about those plans and talk about the proactive activities that have happened up to this point in time, give you some of the financial background of the plans as we see them at this point, and then talk to you about some of the trends and also what we're looking for as we move forward with the development of the request for proposal for your health plan.
Excuse me, Mr. Chair. I had requested in an email yesterday, I don't see it included in this information. Can I get a printout of what I had asked for in that spreadsheet for the presentation? I had asked it via email, and I guess I just assumed it would have been included, or maybe I'm missing it Is it not, is it in my material, I'm just not looking at it?
It's in your email.
Can I, okay,
I got another one if you'd like.
can I get a printed copy? I guess I just assumed it would have been included with council information in this presentation since it was requested. It's not just for me, I'd like the entire council to have a
Yeah,
copy.
if you could, that's with council members here. Go ahead, Mr. Robinson.
Thank you. What our objective is to provide a clear and concise request for proposal that has measurable results and that is inclusionary, so that as we're looking at some of the different options, all of the options would be available for you for review. One of the things we thought to begin with is to just give you a little lay of the land and what happens with your health plan as to how it's set up and the benefits that you provide to employees. Primarily, the health insurance and the dental insurance that is a part of the health plan is included for employees and dependents. You pay a considerable portion of that as the employer. 86% of the county dollars for the plans are yours. The employees pay the rest. You also pay for dependent coverage as a part of that too, and you're paying 71% of the dependent coverage as well. Term life insurance and long-term disability is available to employees at county cost, and employees have the ability to buy up for other services and other benefits that are a part of the plans themselves. As far as the overview of the health plan itself, this is considered to be part of the Volusia Health Partnership Plan that took place back in 1993. You moved to self-funded at that point as opposed to fully insured. The difference between the fully insured and self-funded is you accepting the risk and any surpluses or reserves stay in your particular account as opposed to being paid in premiums. The plan itself has in-network and out-of-network benefits. And there's a ripple effect of those in-network benefits we'll be talking about as we move through the presentation and talking about that as well. The medical, pharmacy, dental, and vision plans are a part of the administration of this plan now. The plan is administered by a third-party administrator, and that third-party administrator pays your claims and answers any service questions that you have. A number of the contracts are contracts that you have developed. The idea behind us starting early, the contracts that you have in place expire December 31st of 2016. And the goal is to make sure that there is a great deal of information that's provided to you and to the employees and to the different union officials who we'll be talking about as we move forward with this, so that we can educate on the plans and come up with a credible and objective RFP. Here's the actual components that you have as the plan itself. Third-party administrator is currently HealthSmart. That's changed a number of years since it started in 1993. Pharmacy is a subcontract with Catamaran that we'll be talking about in a little bit as we move forward with this. The network is multi-tiered as you have the network now. The primary focus on the network is the Volusia Health Network here in Volusia and Flagler counties, as well as the Florida Memorial Health Network in this area as well. In addition to covering the Volusia and Flagler County areas, a number of your employees seek services in Seminole and Lake and Orange and Osceola counties. That particular network has been expanded, and it's through that Florida Memorial Network where it has been expanded. For those individuals that live outside of this area or seek services or need services outside of this immediate area, you have multi-plans that helps with that particular service as well. And discounts are available through that particular process. And you also have the chiropractic network that's a part of that as well. Plan management is another component of this, as well as the employee benefits, the employee assistance program that helps with a number of conditions that employees find themselves in. The premiums, we thought we would give you a little history of the premiums as well as they're set up now. Currently, on a monthly basis, and the premiums are paid on a bi-weekly basis, but we did this on a monthly basis so that you could have some sort of comparison of this. The current premiums are listed in the column that shows the $32.50 that employee pays, and then the differences that an employee with a spouse or 2 children, 1 or 2 children, or family would pay, as well as what retirees pay for their particular benefit today. Those premiums will change as of June 5 of 2015, so those will be increased as a part of the employee contribution that they have through payroll deductions, or the retirees paying on a monthly basis for their premiums as well. The plan itself is a plan that's considered more of a PPO plan with some extended benefits, the way that this is set up. The column that says in-network, local and regional, for individuals that utilize the network in Volusia and Flagler and the surrounding counties, would be in that first column, where you have a deductible that would be in existence first, the $250 or the $750. That applies to major radiology services, and we try to asterisk those so you can see where that does apply. Primarily, the plan for those individuals that use the in-network benefits are co-payments. Co-payments are fixed dollar amounts that an individual pays when they receive services. We showed you the office visits of $25 and $40. It's $25 for an office visit for a primary care physician, family physician. It's $40 for a visit to a specialist, cardiologist, orthopedic, so on. Inpatient care is available at a daily rate, so it's $250 a day for up to 3 days. So it could cost someone $750 if they go to one of the networks in this particular area. Pharmacy is available at $20, $35, and $55, and what that refers to is the...
I have a question.
Yep. One name for a moment. Yes, Ms. Kuzma.
I just need to make sure that I'm clear on this. The office visits would be increased from $25 to $40?
No, ma'am. The office visits are $25 for the primary care for family physician,
And for the
and for the
specialist,
specialist it's $40. There's no
What is
discussion.
it today?
That's today.
That's what it is today.
Correct. These are, I'm sorry, I should have stated that. These are benefits that are in existence today.
All right.
And it's not looking at changing any of these benefits at this point in time. The purpose for the RFP would not be to change any benefits. The only thing that changed would be the payroll deductions that we talked about as of June 5.
All right. Thank you, Mr.
Please, if I may, one moment, sir. Ms. Days, you have a question, something we've already gone over, might as well hit them, because you're fast and furious. I mean, you are just rocking and rolling. Do you have a question?
No, just a point of clarification, I would like, the report that, the analysis that I have is not the one that includes the percentage change that I asked for, what we just took a look at, does not have that. Oh, yes, it does, excuse me, the second one does, it does, excuse me. Thank you, I'm looking for bars and stripes and lines. Thank you for that.
Okay, so you're good now? Okay. All right, you have the floor, hit the floor running.
Okay. The $20, $35, and $55 for pharmacy is on generics. Generics are $20 for a 30-day supply. Brand preferred drugs are $35 and then $55 for those that are non-preferred. Your primarily, the drugs that are filled are generics and at the $20 level. For those individuals that live outside of the immediate area, outside of the Volusia, Flagler, and outside of that extended network that you have an expanded network that is statewide and national. That expanded network has a little different co-payment structure or co-insurance structure as it's set up. That structure is based on a $500 deductible, and then the plan pays 80%, and the individual would pay 20%. So on a $1,000 charge, that would be the negotiated rate outside of this area in that particular for that particular instance. That the individual, after meeting their deductible, would pay $200, and the plan would pay $800 for that particular service, as an example. And the pharmacy is the same. There also is a stopgap for those individuals that would find themselves in a facility that would not be a network facility, and that's what you see in the last column. And again, just to reiterate, there's no understanding of trying to change the benefits at this point. The idea is to look at the benefits we have and then find an objective way to come up with the administration of that. One of the things that we were asked to do is do a comparison of the plans in this area and compare some of the counties to the plans in this area. And one of the areas that we did and tried to look at this was use the minimum values, the values of the plans themselves. And we tied this into the healthcare reform and how plans are measured currently for healthcare reform. You probably have heard the bronze and the silver and the gold and the platinum plans being used as a part of the plan itself. The way that these plans are set up and the way that they're set up as far as the federal government is concerned is that plans that are at least a 60% plan or a bronze plan are considered to be affordable under healthcare reform. Affordable meaning that's one of the tests that you have to have for a health plan in order for it to be considered a valid plan that would be offered to benefits. And what that means is a 60% plan is it means that 60% of the benefits are paid by the plan itself. So if a charge for using that $1,000 charge that we had talked about before, the plan would have to pay 60% or $600 of that $1,000 benefit. The employee could pay $400 of that benefit, and the plan would be considered affordable. In looking at the plans themselves, your plan is an 87% plan, meaning that $87 out of every $100 is paid by the plan, and then the other $13 would be paid by the employee as out-of-pocket expenses. And we'll show you how that equates to your plan itself and what it does in dollars as we move forward with this portion of the presentation. That is in addition to some of the premiums that individuals would pay and the breakdown of those premiums. And we'll explain that to you in a little more detail as I go through this presentation too. This pie chart shows the breakdown of the costs that are a part of the plan itself. This would be the whole 100% of the plan, not the 87% of the plan. The 87% of the plan is the $40.8 million that you see as the total premium that's paid for the plan itself. And in addition to that, you have the out-of-pocket expenses. The breakdown of this, we showed in this particular slide, you as an employer are contributing $25.6 million on an annual basis. This was for fiscal year 2014 to the plan itself. Employees contributed an additional $4.8 million, and retirees contributed an additional $2.6 million to that benefit. There are reserves that have been used for this. You being self-funded gave you the option and opportunity to take some of the lean times and use some of your reserves for that. We'll show you those figures and show you how that was impacted in another slide that will be coming up in a few minutes. So that's the $40.8 million portion of the plan itself that the premiums paid for. In addition to that, members, employees, dependents paid another $5.9 million in out-of-pocket expenses. The out-of-pocket expenses would be those deductibles, those $25 for the family care, family practitioner or the family physician, the $40 for the specialist, all of this, the monies that are paid for hospital stays. All of that would be those out-of-pocket expenses. So employees, members are paying an additional $5.9 million. So when you look at that total pie and the total cost of that plan itself, it was $46.7 million, of which premium paid the $40.8 million. So any changes to that, if you changed your plan from an 87% plan to a 60% plan, the total cost would still be $46.7 million. It would just be how that would be divvied up. So employees would pay more out-of-pocket expenses with that change as it would be set up. One of the other things that we did is looked at your comparison of your plans to others and looking at trends from one year to the next. This particular slide shows a change in trend over the last 4 years. The red lines represent your trend over the last several years in medical costs, and the blue line represents what the national trends are as measured by Siegel on an annualized basis. So you can, from this chart, you can see that the 3 out of the 4 years you were below that national average, and 1 year you were above that national average. And we were asked to see what caused that increase in that year. You had additional hospitalizations in that year. More people used inpatient admissions that year than in some of the others. And the 2 areas that we saw as the highest areas of cost in that area were cardiovascular, heart problems, and also musculoskeletal, backs, knees, joints. Back to what Mr. Deneen talks about is that sometimes the older we get, things start wearing out, and they need to be fixed.
Yeah, he did have a birthday last week for the record, but that's okay. Just, Mr. Manager, sorry.
There's another way that we look at the actual trends, and that's trends over time. And the trends over time, we went back to October of 2009 and looked at your trends. And this is an actuarial analysis of looking at a rolling 12-month average of claims over time. It kind of it equalizes out from month to month the claims themselves. The actual red squares represents each an average of 12 months. And you can see how the graph changes over time. In 2013, we talked about some of that increase where you see some of where we saw a spike in some of those claims. And you can see where the red line jumped a little bit in 2013 to reflect that particular increase. You see now a little more of a flattening out of that particular line, and that's good news because we like to see that flattening, or in many cases it would be nice to see it decrease, but that doesn't seem to be the case in healthcare because of a number of different issues with that. So the actual trend that you're having now is about an 8.8% trend, which is close or right around what the national trends are at this point in time when you look at your medical and your pharmacy. The green line that you see, and the lines that you see that are represented, and the circles that you see represented in green, are the premiums that have been collected over time. So you can see that over the last several years, that the actual expenses have been higher than what the actual premiums have been collected. And you had the luxury of being able to use some of the reserves that you have and that have been built up over time, the fund balances that you have, in order to help with some of those shortfalls. And that got a number of counties, you as well, were able to use that instead of taking money out of the general fund to pay for some of those particular costs. Here's I told you before we would look at some of the numbers and see how this would be impacted.
Mr. Robinson?
Yes.
Yeah, thank you, sir. If you could go back one slide, real quick. Yes. Now, that red line there on the graph is depicting medical claims, dental claims, as well as prescription claims, correct?
That's right.
Is it possible for you to give me a breakdown of, on the same kind of chart, our medical claims, our dental claims, and because you're lumping them all into one big, I know it's one big policy. I mean, we're trying to say, why did we make such a spike? Is it
Absolutely.
because medications went so high, or because it costs $1,600 to get one tooth repaired? So I would like to get a breakdown of
We have that. In fact, there's one of the slides that we did have in one of the original decks that we removed, but yes, we do have that. So
If you could just get that to me, I'd appreciate it.
yeah.
Mr. Robinson, the other thing for the council's sake you need to appreciate is where he shows the difference on the premiums versus what it costs. It was a conscious decision of the previous council, when we were not giving raises, when we were cutting the workforce, not to increase the cost to the employees. And that's what, we had enough reserve to allow us up till this point to use the reserve and still stay within the safety margin of reserves. I talked to the council about what they wanted to do because we could have increased the cost to employees. Council looked at the numbers, we gave them options, and now remember, there were some tough choices we made about not giving raises, and we were reducing the workforce. They consciously chose to use some of the reserve, and now we've only started to raise the premiums for employees. But that was a conscious decision, and we didn't do it in such a manner that it caused us to lose stability in the fund. We only brought it down, where we're getting to now, to where we can't do it anymore without starting to undermine financial underpinnings of the fund. So what we used was the margin, and that was a deliberate thought of the council. That previous council would have been in your spot today, and I think they would have done what we had to do recently, which was increase it to employees. They wanted to wait, use that money up, and start doing it when we got to the point where the economy started getting better, and we wouldn't be phasing out positions, and would also maybe be giving a raise. And so that, I want you to know, that was a conscious decision. That didn't happen by accident. Thank you.
This is looking at 3 fiscal years, looking at 2014, 2015 projected, and then 2016. You saw a pie graph of some of the costs that you had for fiscal year 2014 in a previous slide. So those are some of the numbers that you see in this particular slide. I wanted to point out a couple things to you as we went down through this, and just to follow up on what Mr. Denis was talking about. You used the one-time reserves. You used the 6.6 million, 6.56 million that you see marked in the yellow highlight there. That's the number that was used to pay the difference in what your costs were to what you had in contributions. And the actual plan cost you $40.8 million in actual costs of the plan. And remember, the employees paid an additional $5.8 million, members paid an additional $5.9 million, I'm sorry, in out-of-pocket expenses. But this is just from the premium perspective itself. And you still have a balance, end-of-year balance, or the reserves that you would have listed there at $17.77 million. So that's the money that's in that fund that you have, that rainy day, or the monies that you've been able to use to help balance this particular portion of the costs that you have. There's a Florida statute, it's 11208, that requires you to file on an annual basis a filing of the financial statements of your plan itself and the stability of your plan. There's a particular requirement of a 60-day reserve that you have in your fund itself. So $6.7 million for 2014 had to be in reserve for that particular benefit. So that's part of that $17.8 million that you have as a part of the reserves that you have there. There have been some activities that are taking place for 2015 to change the contribution levels, not only from you as a council, but also from employees and retirees. And you can see the impact that's going to have on fiscal year 2015. Your contribution went up close to 15%, and the employee contributions went up about 39%. And looking at their percent of increase, a lot of that is because it went from $25 to $35, so it's a 10% a $10 increase, but it creates a much higher percentage when we're looking at those percentages. And also there was a difference in when it was collected and the number of months that it was collected in. So that's one of the reasons for that particular increase that you see. So the use of reserves for 2015 is projected to be much less than the use of reserves in 2014. Down, cutting it basically in half, a little more than half. For the $42.8 million we're looking at, or $7 million we're looking at for the plan itself. So at the end of the fiscal year 15, there's still a projection of close to $15 million that would be a part of that plan itself. And then this is projected in 2016 as well, and you can see the impact that it has and the percentage changes that would be for 2016 as well.
Yes, Ms. Kuzak.
In this line, the use of one-time reserves for 2015, it goes from, what's the difference? Why is it that there's such a decrease in the projected amount?
Because of the increase in the contributions. So the contributions from you as the county went from 25.6 million to 29.4 million.
And it was,
that's one of the reasons.
we charged the employee.
And then what the employees are charged.
In other words, this was, remember when we added, this is the first time we started making the employees pay more. And that was one of the big changes, with the employees had to pick up more of the cost of healthcare.
That also is the reason why we have the increase in the 60-day requirement?
It's because of the claims, the increase in the 60-day requirement, because it's based on your claims totals. So the claims are expected to go up for 2015. The claims going from 39.75 million to 41.6 41.6 That's the increase in claims. So as the claims
So that's a
increase.
projected increase in claims?
Correct.
Was that?
Projected. It is projected. And then 60 days would be a factor of that increase as well. So that's why that would go up as a reserve amount.
Ms. Kuzak, also, which will help answer your question, if you look on the percentage change column,
Yes.
if you look, the employer contributions went up 14.9, the employee contributions went up 39%. That was remember the tough decision we made to tell employees that they had to pay more.
All right.
And maybe to explain a little differently too is you're going to need $42.67 million to balance that particular portion of your expenses when you look at your claims and your administrative expenses. And you're getting all but $2.8 million from contributions that are coming in from county, from retirees, from dependents, from employees and dependents.
That answer.
Thank you.
What has been done over the last several months, years, in looking at the plans and being proactive? Well, we can talk about some of the things that have happened recently and some of the management functions that have taken place as well. You know, some of the current improvements that we've been making is looking at analyzing your actual costs and your utilization. And that's helped us make some of the decisions that you'll see not only as a part of the future discussions that we'll have on health plans, but also looking at how we can encourage members to utilize services wisely and efficiently. Now, one of the areas that we saw was a difference in cost in emergency room and increased emergency room usage, versus urgent cares. The urgent cares are your central cares and some of the places where you go for respiratory and some of the issues that aren't as life-threatening as an emergency room would be. And in looking at that, we saw a difference in the network availability of urgent cares. So your benefits management team went out and had the networks increase the availability of facilities and urgent care facilities for people to use. In addition to that, we looked at some of the freestanding facilities that would be available. Where you can get an outpatient surgery at a freestanding facility, versus an outpatient hospital. And the same way with some of the radiology services. And in doing so, expanding that network so it provides employees and members with a little more access to that. And that hopefully will help with the cost over time. And we also, in the negotiations with the subcontractor, Catamaran, we were able to negotiate better discounts over time. And those discounts were over a 2.5-year period, that the projected savings would be around $2 million when we looked at those projected savings. That's not an annualized savings, as we want to point out, but it was over the length of that contract with the 2.5 years. And it's not saying that the pharmacy rates are going to be $2 million lower because of the trend that we see in pharmacy. It's just that it's particularly in specialty pharmacy, and we'll talk about that in later times when we get into more of the details on that. We also had an issue with some of the regional network, that we had talked about earlier that we have through Florida Memorial. There was a problem with the network in Lake and Seminole and Orange and Osceola counties that becomes pretty important to a number of your employees and members. And we were able to negotiate an arrangement there that will save money as we move forward with that. One of the other things that we're looking at is to break out your dental. You talked about the dental being a part of the health plan and the vision being a part of the health plan. We're looking at breaking those out at this time so that next year we can concentrate specifically on the health plan and then looking at some of those other benefits in a way that we can hopefully improve upon those benefits and improve upon the cost of those benefits at this point in time. So stay tuned. We have some requests for proposals that are out now that will be back within the next several months with the review of those, and then there'll be a recommendation one way or another to do something with those as well. Claims audits have been done on a regular basis, so that you can see that your third-party administrator is administering your plan in accordance with the accounting standards that are important there. In addition to that, your HR management, the benefits management team has been able to negotiate some flexibility with some of the unions so that we can move forward with some of these plans and keeping them informed as we go along with that as well. And we're talking about that a little bit as we move forward too.
Mr. Robinson, may I interrupt you for a second? On working with the unions on plan flexibility, one of the most important things that we have negotiated with our union, and it will culminate this afternoon with the Teamsters, is that we've had multiple year agreements now, and even though the issue was raised by especially their attorneys about the right they have to negotiate all the aspects of healthcare, becomes extremely difficult to do. And in a lot of ways, if
depending upon how you negotiate, can undermine your program because you can splinter it. It's not in the best interest of the employees, not in the best interest of the county. I will tell you that after a lot, I mean a lot of serious discussion, in all the cases, including the Teamsters, which are going to settle here this afternoon, they have all waived their right to negotiating health care. I have to make that clear. That is a big decision on their part, because in essence, what we have talked to them about and what they are agreeing to is that they trust that we will try as best we can to keep a quality health care, and that they are acknowledging that they'll accept that health care with increases in co-pays or premiums that the council directs during the period of time of the contract. I want you to understand that is not a small thing for the unions to agree to. That means they're put in, instead of trying to negotiate that, which is obviously a big issue, they're putting their faith in the fact that the council will try to deal with this issue, and as in the past, we've been more than fair, that we'll continue to be fair and try to understand and do the best what's the best for everybody, the citizens, the taxpayers, and the employees. So I have to, pardon me? And their families, absolutely. And so what I want to point out, because I owe it to them to make sure that you understand that they've all agreed to that voluntarily. And that, the other side to that coin is, what it means is when we decide something, we can go ahead and implement it. There are no issues about implementation. And they have to accept what we decide in terms of what we're going to do. That could be changing the healthcare benefits, changing the co-pays or whatever. But it would be done uniformly across the county. And so I'm happy to say I think that is a big thing to have negotiated, and I think that there is a level of trust between there is a level of trust between the non-union people. I mean, they choose in a lot of cases not to be union. But I think it's a level of trust with the unions that they deserve to be acknowledged for, because this is a contentious issue everywhere, and people are very fearful of what could happen to healthcare. So in all fairness to them, they've given us an open door to allow us to try and do this so that we can do something. The beauty of doing it uniform across the county is it's better for the employees and their families, in my opinion, and the citizens, because you can do something where our buying power is better if we're doing it uniformly with all employees. Then that whole group of almost 3,500 people comes under the same plan. Thank you.
One of the things we talked about earlier is that the contracts that you have in existence today expire December 31st of 2016. So we're looking at this being a process that's going to take some time to get to that particular time, but we do have the time for that. So your senior management has been proactive in wanting to start something now, so that it provides the maximum amount of time for input, for thinking about it, and for coming up with plans that are going to best suit your needs, and gives us the time also to educate and to listen to different ways of doing things as well. We were asked to address some of the current trends that we see and what some of the health plans are doing at this time. And you see a number of larger groups looking at the self-funded arena, as you have been in for quite some time, because of the flexibility and because of the options that you have in that area. We are not going to just have the request for proposal limited to self-funded plans. We have been asked to be inclusionary in that. So if a group can come up with a fully insured plan that would be sustainable over time, that's something that would be considered to be evaluated as a part of the plan itself.
Mr. Robinson, that is a big point. When asked, because I've had a lot of people ask me this, I believe as manager, my recommendation is, while we've been very successful on a self-funded plan, that I think in the best interest of the council and the citizens is that we consider all. And because I think the world has changed. That does not mean that we automatically would get away from being self-funded. If it turns, you should pick what's in your best interest. The interesting thing is the trend actually is coming back to self-funded, which is interesting because you have a lot more control in some cases over it. But the fact of the matter is, I want to make sure that the community out there, the business community knew that we are going to be open to whatever is the best plan for everyone, for the citizens, the employees, and for the taxpayers in terms of what it costs. So we are open and we will accept proposals on both, self-funded and non-self.
And there are certain taxes that are built into the fully insured that would be a part of that and disclosed, and that will be able to be analyzed when we look at the final analysis of those particular numbers as well. We see a number of groups going to higher out-of-pocket expenses to employees and members, passing the cost on to the actual individuals that are using it. Some channeling it into where it's more expensive, individuals will pay more, where it's less expensive, they get a break on the cost of those particular services. There's an emphasis more on integration of some of those benefits, where there may be a network that has a combined network instead of 2 or 3 that may be more efficient for you. So we'll be looking at those and looking at the current situation as well. The emphasis on quality and affordability. It's nice to talk about the affordability, but also we believe that the quality is a big issue, and that's an issue that we think that it has been supported, and we think that's a support that you have as well. We see an increasing emphasis on what we're calling adherence-based types of programs. Programs that have the employee or member become more responsible for their health and some of their initiatives. Showing improvements in screening results, or showing costs for those people that are tobacco users as a way to try and modify behavior so that people are utilizing services for their optimal health. We also see some improvements in some of the areas of condition-specific types of programs, diabetes programs or hypertension programs and whatnot, that will help people in those particular areas as well. We talked about some of the direction that we're looking at, and we think that there's an importance on quality care and provider networks as 2 areas that we will concentrate on, because we think that's an important area for you. Utilizing the services of the hospitals and the providers in this area so that people don't have to go far for care, but also providing that bridge and that bridge to centers of excellence as well. So you'll see a great deal of emphasis on quality, on efficiency, and on the provider networks as a part of the RFP itself. In addition to that, we see some the other issues that will be analyzed and evaluated as a part of the plan itself, and that will be just the customer service and the administrative services. It becomes important because we want to make sure that that's done well. The administrative services will be looked at separately, as well as the network provider access that we had talked about. Looking at health improvement areas that will be a part of the RFP process as well. And then one of the things that we think is very important is to be able to measure and guarantee results and guarantee costs. We don't want someone coming to you and saying, trust me, we have a great idea, but we can't guarantee the cost or don't know what the cost is going to be, but we think it's going to work. We think it has to be measurable and quantifiable so that we can come back to you and say that this is something that we believe will work. We like the innovation. We like some of the different things that are out there. We just want to make sure that there's some guarantees for you in that so that you have a good sense that it's going to be controlled and managed in a way that will work. We put together a timeline for the actual development and of the RFP itself. We will be, after this particular presentation, we'll be doing presentations to employees and union officials to educate on the cost and talk about the cost of care itself. With you being self-funded, all of the claims come out of, you're paying all the claims. So the more that we can be efficient and effective with the claims costs, the lower the cost will be as well. We're looking at having the process for developing the RFP and developing the scope of services. The scope of services is what we're going to put out and what we're looking at for that individuals would be responding to, companies would be responding to. So that will come back to you for input and for action, as well as the RFP itself. And different timing points through the particular process to get us to a decision by next May, June for you. So that you can make an informed decision, involve you up front, have you give you the information that you need to make an informed decision through the committee input, and then the implementation of that for January 1 of 2017. a massive effort, and there's a great deal at work here. You're looking at the expense of, $40 plus million, of which you're contributing the lion's share of that $40 million. So it is a huge, has a huge impact, not only from a financial perspective, but also on the impact it has on your employees and their dependents and retirees as well. I'll answer any questions or take any comments and respond as you
As you can see, this is just an opening salvo and a long process. I think Mr. Robinson has a good handle on where we have to go. One thing I will tell you when we open up this bid to both us being self-insured or not, the one thing I know as a manager you have to look out for is that if we decide to go away from self-insured, Ms. Robinson touched on it, but we're not interested in some lost leader. Once you dismantle your system, get a lost leader, and then all of a sudden the costs skyrocket, and you are stuck. And so if we go away from self-insured, we have to have some guarantees over the long run that we're going to have, we're going to result in good cost containment while still high quality for our employees. The other thing which is unique about healthcare in a sense, as an employer, in no way, shape, or form can we turn this ship quickly. This is too many people's lives, too many people that are already with doctors that have illnesses or whatever, and they have, like I said, they have the right to negotiate it once these contracts are up. Bottom line is, no matter how hard we try, you cannot change this quickly. You can, because it's too involved, too many people and too many dependents. So whatever decision we make, we'll have to take our time making it, but we're going to try and assure that whatever decision you make, we can live with for at least a 5 to 10 year period after that. So this is just an opening salvo to get us going. I appreciate your patience, and I know a lot of you know this already, but I really think it's important for the public to hear this and for our employees, a lot of which we're tuning in today.
All right, Ms. Denny's, did you turn the light back on?
I did. Are
Okay.
we ready for council questions or not?
He said, are there any questions that you?
Yeah, going forward, when we get these presentations, I want it all included, the plus and minus, the percentage changes as we look at bids, and in looking at this, and I'm gonna go there, I don't know that it's a real piece to it, but it's something I ask every year we get the CAFR. I'm gonna go to the OPEB. We still have a liability, and it's increased almost 100% for our retirees from 2010 to 2014. So when we're looking at these numbers, council members, that's why, I look at this at the CAFR, and I know I've been told, well, if we dismantle the program, we don't have that liability. Well, I don't think anybody's gonna be in that position, or we wanna lead out with that as an anthem on why it's not an issue. It is an unfunded liability that we are responsible for. It's at the bottom, on the other post-employment benefits, the OPEB liability. It's a very complicated issue, but it's one that we've got to be aware of. And there's red flags on this one. I've said that every time the CAFR report comes out every year. This one concerns me more than anything else we do. We're talking about the fire fund. We're talking about funding streams and responsibilities that we have, that we've made in good faith and will continue to make and live up to, but that's a number that we need further explanation, probably at another time, but I'm going to back up after I say that. And as I'm looking at these, and I'm looking at the percentages, and I understand we don't know what the claims liability is going to be. It's unique. Life is unique. It doesn't schedule our traumas and or tragedies and these issues. But something changed numbers. Your numbers changed between the last PowerPoint and the one we got today. The reserves are different from 2014 actuals changed from the two presentations to the one.
It changed a little less than $100,000. Yes, it changed based on the once those were numbers that we got back from finance. So we revised them based on the most current information that we had.
Well, I would think 2014 actual would be current.
John?
They were the final audit.
The first presentation didn't have the final audited numbers,
And so the second presentation that you have revised, we had updated some of the numbers for the final audit, once we got the audit opinion.
We just received that.
We had just received, we
Okay,
wanted
so-
to make sure it was right up to, tied to the
This is
capital.
the final
exactly.
audited number, so you can
Yeah.
match
So
one to
you
another.
match it to the
Well, my
capital.
conversations with you, please give me that heads up before I get here and I take a look at it and say, why am I looking
No
at
problem.
different numbers? You know.
No, it's good that you pointed it out, because what we don't want is someone comparing our CAFR now and our final audited number to this and say it's different. So what they did was make sure, we should have let you know that.
That this, yes, going forward, and that, because I'm gonna be asking a lot of questions, and I need to assume that my baseline data, where we're going with our benchmark information, I've got to assume it's accurate, and I'm going to assume that going forward. So, with that, it's a complicated issue, and I get it, and I understand that there's gonna be some things that may even change for us, who knows what's gonna happen at the federal level, or other issues, an election can change everything, we understand that.
Well, Ms. Denny brought up something that, I want to talk a little bit about. This is another thing. This OPEB is nothing more than an unfunded state mandate.
It is.
But what they do, here's what OPEB is. OPEB is the cost, see, this doesn't happen in Ohio, it happens here. The state requires public employers to offer to their retirees that are not on Medicare the health program and the rates that they have for their current employees. Now, here's your problem. That group, okay, has higher health costs than your current employees. I am not allowed to charge them by state law that extra amount. I can only charge them what I charge our normal employees. Well, it would make no sense for our normal employees because they don't have that kind of history. So we're required to carry that. Now, the number they show is what it would take to carry everybody out over the next 30 years. But you have no choice. In other words, and now, here's the other thing. The great majority of these people, okay, are a lot of your first responders, and a lot of your special risk, because they get to retire earlier. So they're retiring at an earlier age, and they're on, in other words, you come off of that dependency when you become Medicare eligible at 65. But I've got people that have all their time in because they don't have to work as long when they're 55 or so. So you got to carry them for a longer period of time, and you're carrying them when they have a higher health cost. And so as she pointed out, I don't think we get credit for this, it's an unfunded state mandate.
Well, it's not just an unfunded state mandate, it is a liability that we are required to pay. So let me make sure, we've had this conversation with Brenda, that's probably my conversation. You know what, in fact, I will defer the OPEB conversation.